I know quite a lot of people in the room, but if I don't know you, my name's Alison. I'm one of the medical education nurses at King's Mill. I would encourage you, if you're tech savvy, if you've got an iPhone, please just point it at the QR code. If you're a Samsung girl like me, you'll need to have a QR app on your phone. But if you could help me out just by scanning the code and giving me an opinion on what it is you think we do all day. For those of you who know me, please try not to be too brutal, especially if you're an ex-student. So I'll give you a couple of minutes just to do that. Contrary to popular belief, we do not spend our day in Costa. We go there occasionally for a meeting, of course. But it's just give you an idea of what we do get up to. So when people have had a chance to scan, we'll just see what the room thinks. This is a cheeky opportunity just to show you a scanning system that we use for feedback at the Trust. If I can get it back over. So I've got 17 responses already, that's amazing. Cheeky, this will be the people that know me, right? I don't even like Quality Street, okay? Quality Street, bottom of the pile. So how many people have got in the room? Few more, but I guess a lot of people won't be able to do it. So I'm glad I put this question in now, because a lot of you have put that we probably work in clinical areas and just have students when they are around. A predictable at least 15% think that I drink coffee and eat Quality Street all day. Venipuncture, cannulas and catheters all day. Feels like that sometimes, but that's not what we do. And thankfully, some of you don't know and you'd like me to tell you. So the orange section isn't all wrong. We do work in clinical areas with students, but as part of our job role. So the medical education nurses at King's Mill are employed full-time through SIFT funding just to work with medical students. So I don't have a job on another ward and just have students when they come. They are my life. So we're full-time employed for medical students, and we take them to clinical areas to do stuff depending on where they want to go. So thankfully, we're not too far off the mark on the basics of what we do. Now, let's get this back up and running. I probably didn't need to do that. There we go. So I was encouraged to do this talk today by my boss over there. To talk about myself, but I don't like talking about myself that much, so I thought I'd turn it into just a bit about the team generally and where it began and where we are now. So this is us. There's me on the left. Just in front of me is Dee Kelsey. She's the medical education nurse for surgery. In the middle is Hayley Lakin. She's quite new to the team, and she's our medical education nurse for MDD and orthopaedics. Wayne Robinson, some of you might have met or heard before. He's our critical illness medical education nurse. And a newish member to the team is Lorraine Brooks, and she's taken over the healthcare of the elderly side of things. So there's 5 of us now. It started back in 2008. I was a ward sister at that point, disheartened, looking for a new job, as most ward sisters are. And I saw this job advertised, loved teaching, thought I'd give it a go. And at that point, the job was a bit of a blank canvas. The medical education team had thought it might be a nice idea to have some nurses around, and came into the job with some loose ideas about what they'd like us to do. So recruiting patients was one of the things, setting up clinical skills training, being available on the wards, that kind of thing. So I'm the only one remaining from the original 2000. It seems like a long time ago. My profile pic is much younger. At that time we had medicine, surgery, MDD, and medicine and geriatrics was a join. I did both at that time, but it got a little bit out of hand as the intakes got bigger, so we had to separate the two. Still a geriatrics nurse at heart, though. In 2012, we got Wayne on board as our critical illness nurse, and in 2016, Lorraine came in to take on that healthcare of the elderly side of things. So it's a team of 5 now. Between us, we have a terrifying 134 years of nursing experience. I'm not going to tell you how many of those are mine, but I think it does come in handy, not just for the teaching side of things, but also the sort of mum side of things that comes in, and being able to offer support to people and sort of pastoral care, stuff that we're used to, so it does come in useful. So what do we do? Well, you'll be pleased to hear that our main role is still to deliver high quality clinical skills training. It's what we were employed to do, and we do still do it. We do it within our own programmes, but between us we're able to cover all of the MACs and all of the examination skills across the board. And we'll dabble in and out of each other's programmes, so I'll dabble around in surgery a little bit, and they'll dabble around in ours a little bit, so we sort of can help out with each other's programmes. But on top of that, we deliver tutorials, we run workshops. It's not all clinical skills. We do some teaching as well. And I've already said that medical students are our main job role, and they're often a bit surprised by that. They'll say, "Where do you work normally then?" And I say, "Oh no, I work with you. You're it." Although I do hang around on EAU quite a lot, because that's where most of the action is. From their perspective, to get good teaching, it's a good place to go, and it's good for people to know who we are. It makes life easier. A study done by myself, so completely biased, in 2014 for my dissertation, I did a little project on what medical students thought about being taught by nurses, because it was quite a new concept then, and I thought, well, we'll just see what they think. And actually, they valued our input more than I expected, which was really nice, and felt safe in trying things with us and not being sort of mortally embarrassed if they got it wrong. I think that was the benefits. They thought it was kind of safer to be wrong around us. Whether that's true or not, I don't know. There it is. So we haven't got a huge amount of time, so I thought I'd just give you some of the highlights. As a team, we're actually a really close team. We love each other quite a lot. We're a really tight team. And because of that, I think we've come up with some good ideas over the years, and we've always been allowed within our job role to try those things out. So we're very lucky in that if we want to try something new, the answer is always yes, and we go on and we get stuff done. So some of the things we've done, we came up with a time skim, which is like a mock-oski, but not a mock-oski, and that's because we're not allowed to call it a mock-oski, but really that's what it is. So that it takes a lot of engineering. It's quite a lot of work goes into it, but it's well worth it. We run 6 or 7 stations depending on the number of students. We bring in real patients, plus or minus actors, surrogates. My son has been roped in several times for various things. And we run it just like an exam. It is timed, they are marked. The examiners, we try and get people that they don't know, so it's not too cosy, and they get feedback at the end of that. So it's a whole separate talk, really. But that's been one of our successes as a team. I can't take any credit for this. Wayne Robinson has been the driving force behind the development and opening of our sim suite, which we now use more than ever. But he wrote the business case, he made it all happen, spoke to all the companies and everything, so he got that up and running. Our medical student Christmas quiz is legendary. Has anyone been at Kingsmill as a student and done that? Might have done. So it's the event of the year, obviously, and huge amount of work goes into that. Big team meeting every year, round about September, as to who's going to take which category, and it's very competitive. There are cash prizes. There's always an ongoing sort of battle between medicine and surgery to see who will win. Clearly, medicine usually wins, but surgery won last year. And this is us, getting into the sort of feeling of things. We dress up on the day. We have Christmas music. They have crackers, tablecloths, a lot. So. And it's educational. I've quite a while ago introduced one-to-one ward sessions with students, which are student-led. So they get a morning, one-to-one morning of my time. They turn up in my office and they tell me what they want to do. And the idea is that we can fill gaps. So some of them want to go around and stick cannulas in people. Some of them want to do clerking practice. Some of them want to do examination practice. And we can do all of those things. And we very much I just like, what do you want to do? And then usually there's some time for a bit of teaching at the end of that as well on whatever we've ended up doing. We've presented at a number of national and local conferences. Lorraine would kill me if she could see that picture. She's holding up our poster there because I couldn't go to the conference after all that. So it went well. So we do that sort of thing. We do examine exams in OSCEs across all the years, so we're used to examining quite frequently. We try and get involved as much as we can in curriculum mapping, self-assessment on the local site, attending CMC meetings, making sure we're involved. I'm certainly involved in the curriculum phase planning for the new curriculum. We provide a freedom to speak up guardian service for our students, which we've done for a few years now. So myself and one of the other nurses, Dee, all hospitals have freedom to speak up guardians, but we have freedom to speak up guardians for medical students. And that was introduced because we know that as a student it can be a little bit difficult to challenge someone who's super senior to you. So it gives them another way of highlighting concerns that they have. And there have been a number of incidents where students have come and said, I saw this in this area today and I don't think it's right. And we've then been able to deal with it or escalate it or do what we think is right. These are some students who survived one of our sim ward rounds. Look, they're all still breathing, they're fine. I have introduced an educational supervisor's annual update because we felt that we were struggling a little bit with engagement of some of our supervisors. I thought, what can we do about that? So we put a lunch event on, invited them all along for a bit of an update. And actually we did another one this year, and the upshot of that was that they wanted a half-day event. They wanted to come and have some extra education themselves. So that's happening in September. And we're just trying to keep people on board because, people are busy and it's, difficult for people to give up their time. They have to feel like it's worth it. So we're trying to give them a bit of teaching as well. We developed quite recently a medical education SSM and a medical education elective. No one signed up for the SSM this year, which is a bit disappointing, having done all the work for it. But the elective, we did have someone along who did a full elective with us in MedEd and I think had a great time. And hopefully in the future we'll want to come back and work in medical education. As a team, we've been recognised by the GMC on a couple of occasions for the level of support we provide to the students at Kingsmill. And it's something we take pride in, we prioritise it quite highly and hopefully that will carry on. So the future of the role, it's going to change, I think, as it is for anyone who's working in medical education over the next couple of years. We've got a new curriculum coming on the horizon. I like a bit of change, so we're looking forward to some new challenges. We're probably going to have to think about the way we teach and how we get that teaching to students. Certainly from a medicine perspective, we're going to have junior, intermediate and senior, and I can't see me managing all that at my age. So, I think we'll probably have to look at how we're structured and how we get teaching to students. And hopefully that will lead to an expansion of the team, maybe some new people on board to try and help with that. I'd like to think we've become an integral part of medical education. And in 3 years I'll get to retire and return if Nikki lets me. And so until that point, I hope we continue and thereafter as well. So I think that's enough of me talking. I don't know if that took 10 minutes or not. Questions?